Hello and good afternoon, everyone. My name is Bethany Hamilton. I'm co-director here at the National Center for Medical Legal Partnership. You are joining us today on October 18th, 2022 for a webinar on developing screening, referral, and service delivery workflows for medical legal partnerships, or MLPs. Let's go to the next slide. As folks are logging in and joining us, let me just acknowledge that today's webinar is supported by the National Center for Medical Legal Partnerships Training and Technical Assistance Award from the Health Resources and Services Administration, or HRSA. Many of the resources that you will find us sharing today, including by our partners presenting today at NAC, are supported by this Training and Technical Assistance Award for health centers, but we will also note that those of you who build medical legal partnerships that partner with hospitals and family support centers, other types of healthcare provider types, will hopefully find the information easily transferable and applicable to your medical legal partnerships across settings. So thank you, HRSA. Let's go to the next slide. So just some brief housekeeping, as you all are probably used to us explaining, everyone is joining in the audience by default on mute. We are utilizing Zoom webinar platform and asking that all questions be submitted using the questions and answer or Q&A pane in the Zoom webinar panel. The chat is open and you're welcome to utilize it. During the webinar, you may also see that some of our panelists, the subject matter experts, are in there and engaging with you, but we will try our best to prioritize the questions that come in via the Q&A, and please, you're welcome to submit the question as it arises. Don't wait, don't hesitate, plug it into the Q&A, and we'll get to it as they come in. If you do need captions, to activate captions at the top of your Zoom, or typically on the top of your Zoom webinar screen, you'll see a handlebar that is highlighted about activating live transcript. So select live transcript and then show subtitle to allow for those captions to be activated should you need captions, closed captioning on today's webinar. Excuse me. This webinar will be recorded. So yes, we will be recording this webinar and posting it on the medicallegalpartnership.org website under the resources tab. We'll also be sharing the slide deck, and our partners at NAC who run the National Resource Center website for health center resources will also be sharing it on that website as well to make it easy to find. So yes, this webinar will be recorded as well as slides posted on our various websites. Again, chat is activated and you are welcome to send messages there, but please use the Q&A to submit questions. Let's go to the next slide. All right, so we're gonna start a poll on your Zoom webinar. Hopefully, if you're not joining us by phone, but you're on Zoom, you'll see a poll pop up on your Zoom platform. First question is, tell us who you are. It's extremely helpful for our panelists in particular to know who's joining us in the live audience today. So if you're an FQHC or a lookalike, please check that box. Are you with a legal services organization, including law schools? That might be a part of an MLP providing legal services. Are you part of a hospital, primary care association or PCA, a health center controlled network or HCCN, an academic institution, or other? If you are in the other category, please send us a chat message and let us know who you are, where you're from. The second question in this icebreaker poll is, do you have a medical legal partnership? I can already see some of the results on my end, and so it's really great to see how much representation there is. So the answer options are yes, no, I don't know, or I am developing an MLP. So again, let us know who you are organizationally, and then also, do you have an MLP? We'll give it about 5 more seconds before wrapping up because we're pretty high in terms of the percentage of participation so far. And let's close the poll and show the results. So if you can see the results on your screen, about 11% of you are joining us from FQHCs or lookalikes. Many of you, 66%, are from legal services organizations, about 3% are from hospitals. Today, unfortunately, we're not joined by the PCAs and HCCNs, but hopefully we'll see them asynchronously tuning into the resources, or will be tuning into their audiences and platforms soon. 17% are from academic institutions, and we'll take a look at the chat to see what other representation we have. 80% of you have indicated that you do have a medical legal partnership. Kudos to you. For those who said no, or you're in development stages, we're here to help you. That's why we're so happy you're joining us today. So that's it. Let's close out that poll. And let's go to the next slide. And thank you all for participating. Let's give us a moment here. All right. So this today's webinar is a part of an entire webinar series that's tied to really our core curriculum that's spelled out in our Health Center MLP Toolkit. So if you go online to our medicallegalpartnership.org website in the resources page, or if you just go in the in the search box for the web page or the website, you'll be able to type in Health Center Toolkit, and you should be able to find the toolkit that we published in October of 2020. The first webinar covered the social needs of the health center patient population, really hitting the reset button and making sure we all understood what the current needs are, social needs and health needs of the health center patient population. That way, as we continue to build and evolve our medical legal partnerships, we're making sure that we not only know what the social needs look like, but we're able to better address those specific social needs with the right and more precise interventions. In today's webinar, we're going to begin to dive into the mechanics, the tools, how to utilize them, how to integrate them into your service delivery workflows. And then in future upcoming webinars, we'll talk about workforce development. In other words, how do you really train the MLP staff to better identify those health harming legal needs of the patient populations? Then we'll touch upon some patients to policy initiatives that MLPs help to address. And we'll also talk about evaluation and sustainability for medical legal partnerships, something we know many of you who are conducting evaluations or conducting research or improving your programs are really interested in learning more about. And that one, by the way, is also going to be complemented by a learning collaborative. All right, let's go to the next slide. All right, our learning objectives for today are first and foremost, you'll hear from the NAC team who will help to describe how the PRAPARE tool enables health centers and medical legal partnerships to better understand patient complexity, address the social needs as well as risk, and demonstrate value. Then we'll also hear about risk stratification principles. So we'll begin to explore what risk stratification looks like and how to use PRAPARE, or how PRAPARE is currently being used within risk stratification efforts around the country. And then you'll hear more about how to really understand and define and design a standardized workflow for your medical legal partnership screening, referral, and service delivery. All of this ties together. We know that many of you are walking through the toolkit, and what we've done is we're moving beyond the 9 core or initial conversations to build a foundation into the mechanics. So I just want to note that for those who may not have tuned into our past webinars last year and the year before this, please feel free to go back to those webinars that covered the 9 conversations so that we can help fill in the gaps. The toolkit is also really well organized and provides information to help fill in some of those gaps. So here are our learning objectives for today. And if you do have any questions as our subject matter experts present, please, again, utilize the Q&A function to pose those questions. So for our speakers for today, let's go to the next slide. You've heard from me. Let me introduce Nalani Tarrant, Deputy Director of Social Drivers of Health at the National Association of Community Health Centers. In Nalani's role, she's responsible for program development, implementation, and evaluation related to identifying patient-level social needs through SDOH data to inform upstream health center efforts that advance health equity. Nalani also focuses on leading multi-partner national efforts that effectively address complex patient challenges through use of PRAPARE, or the protocol for responding to and assessing patient assets, risk, and experiences. That's the PRAPARE screening tool. And we hope that most of you, as we understand, are using it to positively impact health equity, accelerate healthcare improvements, and transform how providers at your health centers and elsewhere understand and interact with patients across the spectrum. We're also joined by Yuriko de la Cruz, who's Program Manager of Social Drivers of Health at the National Association of Community Health Centers. She partners with health centers to identify those patient-level social needs and use SDOH data, specifically through PRAPARE as a screening tool to inform upstream community efforts that advance health equity. Yuriko started her career actually as a Peace Corps volunteer in the Dominican Republic. And then after her service, she worked as a community health worker in Newark, New Jersey, first at a nonprofit and then later at a hospital. Yuriko later worked in training and technical assistance and grant writing for HIV/AIDS prevention, substance use, and cultural competency programs on a national and statewide level. Thank you to both Yuriko and Alani from NAC for joining us today. Also, we're very happy to be joined by Attorney Keegan Warren Clem. You all may have seen Keegan on several of our past webinars, and we're very happy to be able to have her actually join us live on today's webinar. Keegan Warren brings a civil justice lens to bear on healthcare design and strategic planning, and specializes in formalized and measurable approaches to social determinants of health and health equity. Keegan has worked collaboratively with healthcare providers across various settings, by the way, serving patients through the lifespan to improve outcomes by bringing patient-centered legal and structural expertise into all aspects of the delivery of healthcare. She also has been a senior manager of targeted legal assistance program for survivors of sexual assault, victims of crime, and veterans. Keegan, thank you so much for joining us today. Again, let me just clarify, because I used her former name when initially introducing her. This is Keegan Warren, Senior Consultant of Health Management Associates. Thank you, Keegan, for joining us today. So one last poll before I go into our main portion of the presentation. Let's launch the next polling question. All right, so on your screen, and let's go to the next slide. All right, so on your screen, you'll see the next polling question. We'd like to know about how you're using your social needs screening data. So assuming that you are screening for social needs, how are you using it? Are you using it to make referrals to address those needs? Are you using it to identify and stratify risk? Are you using it to improve care quality and delivery models? Just want to note that our poll in Zoom messed up our actual wording on this question. So are you using it to improve your care quality and delivery models? Are you using it to identify staffing needs, or all of the above? We'll give this about 5 more seconds before closing out. Get your answers in, folks. How are you using your social needs screening data to make referrals, to identify and stratify risks, to improve care quality and the delivery models, identify staffing needs, or all of the above? All right, so answers are in, or responses are in. It looks like 45% of you are using it as expected on this MLP focused webinar to make referrals to address those needs. Interestingly, 0 people responded in the category of identifying and stratifying risk. So Yuriko, Nalani, and Keegan, this is the area that we anticipated we would want to address for today, and we're looking forward to your presentations that speak to risk stratification. About 10% of you are using it to improve care quality and your delivery models. No one is using it for identifying staffing needs. So Keegan, looking forward to your remarks on quality improvement and how to use this for really building your medical legal partnership and workflow design. And then 45% of you actually said all of the above, right? So we'll look forward to hearing from those of you who said all of the above. Please do engage in the chat and Q&A, because that's our shared learning approach here. Thank you all for engaging in that last poll. So let's kick off the main part of the presentation. Next slide. First, let's make sure we're all on the same page regarding how we talk about medical legal partnership. The definition that we use here at the National Center, thanks to all of you in the field that really helped us come to this definition for the traditional MLP, is that as it appears on the screen. Medical legal partnership is defined as an intervention where legal and healthcare professionals collaborate to help patients resolve social, economic, and environmental factors that contribute to those health disparities or inequities, and have a remedy in civil law. I do want to note that we are beginning to see more and more of this evolution of the model go into spaces where You have additional types of providers, additional types of entities. Even on the legal side, we've seen MLPs partner more directly with public defenders' offices and work with social workers to screen and refer patients to address civil legal needs and healthcare needs alike. So we look forward to learning more about how those MLPs are evolving to continue to swim upstream. And also, it's not just about resolving these factors, but doing preventative legal advocacy to eliminate the problems before they occur. All right, let's go to the next slide and just make sure we're also all on the same page with regard to what the core activities are of a medical legal partnership. So in the traditional MLP model, you're really embedding lawyers as members of the healthcare team. So you can see lawyers in these medical legal partnerships really conducting that traditional legal assistance, helping those individual patients address their legal needs and creating that sort of impact on the entire model for care where everyone's able to now practice at the top of their licenses. But MLPs go beyond that, right? They also conduct trainings for the entire team, especially on the healthcare side, right? To really help that health center workforce better address social determinants of health. They're also creating clinical level changes. And as we'll later cover in this series, they're also doing that, continue to go upstream and do that policy change work. So we have several examples on the National Center's website, and Danielle on our team and I will be in the chat and we'll plug some of those additional resources. But if you go into Toolkit, you'll see some examples. Ultimately, through these various activities, MLPs are creating healthier patients individually at the patient population level and at the population level in general. They're strengthening the health center workforce and improving health equity. All right, I am now very happy to turn it over to our colleagues and friends at the National Association of Community Health Centers, Nilani and Yuriko, for their portion of the presentation. And again, everyone, thank you for joining us, and please submit your questions using the Q&A. Nilani and Yuriko, all yours.
Great. Thanks so much, Bethany, for introducing us and setting the tone. And it's really great to be with you all today. Next slide, please. So we're going to share a little bit about what we do in terms of PRAPARE. And on the next slide, in terms of PRAPARE, just want to acknowledge the longstanding partnership between APSHO and OPCA. So APSHO is the Association for Asian Pacific Community Health Organizations, and OPCA is the Oregon Primary Care Association. So how to get that out the way, but want to acknowledge them as partners because they were part of the creation. We all worked together to create PRAPARE. So you'll be hearing from us again. Nilani she'll come right after me, but I'm Yuriko. Nice to meet you all. So on the next slide, I think you can probably skip over that one as well. I'm sorry. And there's our contact information there. So we have two polls that we'd like for you all to complete for us. So the first one is just, we're wondering, if you're collecting social needs data, if so, which tool you're using, or if you're not using, or if you're not collecting social risk data. And then we also wanted to get a sense of your level of understanding with the social drivers of health, or social determinants of health, otherwise as it's known. So I'll go ahead and give you all some time to complete that. And for the folks that are managing the poll, just let us know when you're ready to close the poll. And we'd love to see the results as well. All right, so we actually have some folks in the room that are using PRAPARE. That's wonderful to hear. We've got others that are using another tool. Awesome. We also have folks that are not collecting social risk data, or others that don't know. So this is all really, really helpful for us to understand. And we just thank you for joining us today. And in terms of level of knowledge, all of you are pretty knowledgeable about social drivers of health. So we've got a good mix of those that are beginners or somewhat knowledgeable, then intermediate or knowledgeable, and then advanced or very knowledgeable. So thanks for sharing that, for completing the poll. So on the next slide, just wanting to anchor us a little bit in terms of some definitions that we like to use when we are speaking with different individuals and we present. So the first one is social drivers of health, or social determinants of health. And these are the conditions in which people are born, grow, live, work, and age. And the conditions are shaped by the distribution of money, power, and resources. Just a side note, our team has adopted social drivers of health just because the word drivers really allows us to understand that there's something that can be done about it, whereas determinants has a finality to it, as if it's once and done and that's it. Where in reality, we know we can do something about these different drivers that are impacting our health. The next definition is social risk factors. So these are the adverse social conditions that are associated with poor health. And these are oftentimes a result of SDOH. The next definition is social needs. And really with this particular definition is really centering and anchoring the patient's role in identifying and prioritizing what are their social needs, what's most important to them, so that it informs the social interventions that they want to participate in or that they want to seek out. And then finally, population health. This is really, it's the definition that describes the health outcomes of a group of individuals, and also really understanding what are the distribution of those outcomes within a group. So if we think about a health center or a community-based organization, really understanding that small pocket of people that you serve directly at the health center or at the organization, and then seeing what are the health outcomes that you see and how does that look across the organization. So in the next slide, we'll see kind of how this all fits together. Again, social drivers of health. These are the conditions in which people are born, grow, live, play, work, and age. And these are the conditions that we really want to think about when we talk about health inequities. Social drivers of health have been shown to have a greater impact on population health and individual well-being than factors such as biology, behavior, or medical care. So as we look at this particular slide, on the left-hand side, you see upstream and then downstream. And if we think about it, it was great when Bethany talked about swimming upstream. Think about our patients. They're swimming upstream across against all these forces against the tide, if you will. So these are all the different forces that they're contending with that's impacting their health, and how we see their health and how they see their health as well is defined by downstream. So that's health behaviors, health conditions, and health outcomes. So really, when we think about all of this and how this looks, out of all these conditions, again, only 20% are accounted by medical care. And that's a really interesting percentage because our medical system really invests more in medical care than in everything else. So when we think about the other factors, the other 80%, it's the health behaviors and the social drivers of health. So things such as education, job status, family support, income, those are factors that impacts a person's health. So again, these are the 80% of a person's health is impacted by social drivers of health. Now, the next slide, I think we have a knowledge check for you all. So we'd love to hear how would you define or what are the social drivers of health? And then the other knowledge check question is, what percentage of a person's health is impacted by SDOH? Trying to make sure that we're all engaged in today's presentation.
Do you want us to read that out, Yuriko?
Yes, please. That'd be great. Yeah.
No problem. So on the first question, social drivers of health include which of the following conditions in which we live, work, play, or all of the above. About 98% of you got the answer correct, which is all of the above. On the second question, which percentage of a person's health is impacted by social determinants or drivers of health, about 64% of you said 80%, which is the correct answer. I just want to note that we have seen those past percentages quoted, but we've learned more and more that it's about 80% now. So that was the correct answer. All right.
Thank you. All right. So now that we've talked a little bit about social drivers, social determinants of health, we're going to go on to the next slide so we can see how this all fits together. So when it comes to understanding social drivers of health and how we see that in our communities, it begs the question of why collect standardized data on SDOH. So really, when we talk about this and when we think about it, these different levels really gives us the why or the use cases of collecting standardized data on SDOH from patient to policy level, right? And so with this data, it's such a powerful set of data that you can use it at all the different levels. So health centers and others are increasing their use of social risk screening tools, standardized social risk screening tools such as PRAPARE, to better understand, document, and address the root causes of not just poor health, but of inequities. Having this data integrated into system can allow care teams internally and externally to collaborate to proactively assess and address client social risk, and can also be used to guide local partnerships and accelerate alignment. And on a larger scale, it helps also inform different policy or funding initiatives, if you will, when we think about reimbursement or even grant opportunities that are out there. This information really helps communities understand what are the priorities that a community has. So these are the different use cases, and we encourage you all to take a deeper dive with that in our toolkit. So on the next slide, when we think about collecting standardized SDOH data, there's really 3 different buckets when it comes to building the capacity for this. The first one is people. Everything is done by people, we know that. So really thinking about who are the people that you have at your health center, at your organization. The next is processes. What current processes do you already have? One thing that we'd like to emphasize with everyone that we work with is there's no need to recreate the wheel. Outline your current process and see how you can build upon that, because you're already doing something really well, so why not build off of that? And then the final piece is technology. Looking at your EHR or different technology or different platforms that you use to assess and address social risks of patients, and seeing how that all comes together. So when you talk about people, processes, and technology, many times you're going to work at all these different, at these 3 different levels or 3 different swim lanes, if you will, because sometimes you'll have to use all 3 together, and sometimes you'll have to focus on one at a time. So on the next slide, I'm really excited to talk about what is PRAPARE. So PRAPARE stands for the protocol for responding to and assessing patients' assets, risks, and experience. Next slide, I'm sorry.
Seems like we're having technical difficulties on Reha's slide. Oh, there we go.
Okay, no worries. So here is the definition, or actually what PRAPARE stands for. One of the things that I really love about what it stands for is really that part about a patient's assets, risks, and experiences. So this is a national standardized patient risk assessment tool, and it is designed to engage patients in assessing and addressing social drivers of health. Back in 2013, NAC alongside APSHO and OPCA partnered together to develop the PRAPARE screening tool. So on the next slide, you'll see exactly what are the different elements that are covered within the PRAPARE. So PRAPARE measures different things. On the left-hand side, you see the core here. These are the different elements that our pilot, that the participants at our pilot program outlined as being really essential to assessing and addressing social needs of patients. In that core bucket, there are 9 items that are outlined in red. These are aligned with UDS measures. So health centers should look very familiar. You're already collecting this information as this is part of UDS. And then on the right-hand side, you'll see optional. And so these are the different measures that our health centers, in terms of feedback during the pilot, they said that this is very important. However, every health center is different, right? So we wanted to make sure that there was a little bit of flexibility in terms of if a health center felt that they had the capacity to address this. Because a lot of times, one of the things that we hear at the health centers and organizations is that if you're asking these questions, you should have resources, which is something that's really important, but sometimes those don't always align. However, wanting to just emphasize that these are the core and optional measures. And many times, believe it or not, we find that a lot of health centers ask all the questions. So on the next slide, I think we have our next knowledge check. So wanting to see what you all, the first question is, what does PRAPARE stand for? And the second question is a true or false question. So the first one is, PRAPARE stands for which of the following? And then the second one is, true or false, PRAPARE data can be used for change at the patient level, population level, and community level. So 91% of you selected the protocol for responding to and assessing patients' assets, risks, and experiences. That is the correct answer. So great job. And then the true or false question, it is true that PRAPARE data can be used at each of the levels of patient, population, or community. So yes, thank you for answering those questions for that knowledge check. All right, so we'll go ahead and move on to the next slide. So in terms of national SDOH screening rates and really thinking about how health centers are doing, according to 2021 UDS data, we have roughly 74% of health centers are using a standardized SDOH screening tool, and about 20% are not currently, and they're in the planning stages. Now, of that 74% that are using a standardized tool, 54% of them are using PRAPARE. So really excited about that. And on the next slide, you'll see kind of the evolution of the reach of PRAPARE, or the uptake or the adoption of PRAPARE. So on the left-hand side, you have 2019, and this is the first time this data was collected. And as you can see, there's more and more states are turning darker blue. So we're really excited about that. The lighter shaded states show lower PRAPARE use, but the states in darker blue are using PRAPARE. Our team will be working on some just general SDOH screening rates in general for health centers, just to get an idea, but just wanted to share that with you all. On the next slide, wanted to provide just 5 I would say high-level reasons as to why you should use PRAPARE to collect data on SDOH. So the first one is the tool is actionable. It is evidence-based, and it was designed through stakeholder engagement. And it is paired with an implementation and action toolkit. The other question, or the other point, is that it's standardized and it is widely used. We know it's widely used, so I just gave you the data behind that, but it's also mainly used by Medicaid managed care organizations. So I wanted to emphasize that as well. And there's also it is standardized with ICD-10, LOINC, and SNOMED codes. The fourth reason is that it is designed to accelerate systemic change. So PRAPARE data can be used to show patient complexity through the development of risk stratification formulas, and it ensures an ability to better target complex patients in need of enabling services or social interventions, such as referrals and case management. And the last reason, probably the most important why of all of this, is that it is patient-centered and it's patient-centric. Something that we've heard from a lot of our health centers and PRAPARE users is that using PRAPARE has allowed them to facilitate conversations and to build relationships with patients. As they use PRAPARE more, they've gotten more comfortable with it, and it's allowed them to really understand the needs of their patient. Now, on the next slide, we'll see a little bit in terms of how this data is used. So these are the different opportunities at hand that health centers take advantage of when leveraging PRAPARE data. So these are just some of the examples. I'm not going to go through all of them, but really, you think about systems level changes, and these are all great examples of how this allows for health centers and their partners to accelerate change across various systems. And not just externally, but also internally as well, when we're thinking about community health worker models, or even other efforts at the health center that are reflected externally. So then on the next slide, so we know with adopting any new tool, or getting started with a new process or making changes, there's always challenges that come to a head, right? And as leaders, we want to make sure to both identify and address these challenges. And these are just some of the most common challenges that PRAPARE users have shared. And so with these challenges, we also wanted to offer some responses or messaging solutions to these challenges. This is very helpful, I think, for all of us to even just understand kind of the why it's still really important to do these things. Now, that's not to say that, yes, you're down all the staff and you might have to make some negotiations that day, but sometimes that, maybe there is that one patient that you can say, for this patient, let's screen for their social needs. And that's at the discretion of the health center. But these are just some common challenges, and wanted to just share them with all of you since they're very helpful for all of us. All right, so on the next slide, this is an example, or rather a framework that we use a lot with our health centers and different PRAPARE users on designing the right workflow for their health center. It's the 5 rights framework. It is a clinical decision support framework, and so it is something that is used within health information technology. And it's something that can help in planning your PRAPARE workflow and implementation in your practice or your health center. And based on this framework, implementation must provide the following to improve targeted health outcomes, quality of care, efficiency, and cost savings. I'm not going to go into too much detail here because there's a lot of great information in the toolkit, but these 5 rights framework is just so helpful. It's thinking about the what, the how, the who, the where, and the when. As you take time to answer these questions, and in the toolkit, there's actually a worksheet that allows you to complete the worksheet. You're able to go through, answer these questions, and it comes up with kind of, you get a better understanding of where to start with where you're currently at with SDOH data collection. So just wanted to provide that as a very brief overview. And then finally, before I hand things over to Nalani, with all of this data that you're capturing, it's also important to build a data strategy. So on the next slide, you'll see that these are just some common steps when it comes to building a data strategy. You want to outline some goals related to PRAPARE data collection, especially as you're getting started or even looking to improve. What are the goals? What are the metrics that you're hoping to measure, and how are you going to measure success? Also have to assess your data capacity and your infrastructure. Maybe you have a lot of capacity internally, or maybe you might have to partner with your PCA or HCCN to think about how to leverage the data. It's also, the third recommendation is developing a PRAPARE data roadmap. And I think this really helps with all staff that are using PRAPARE or completing PRAPARE, understand that their interaction with patients in that face-to-face or one-to-one encounter, if you will, has larger implications of really understanding how this data is used outside of the visit. Then you also want to think about data analysis, and then thinking about, once you do the data analysis, what are the findings? What's the data saying? And then after you figure that out, then you want to act on the data. And then you finally want to evaluate outcomes, and it's an iterative process. I would definitely encourage you all to tap into data folks, that this is their jam. This is something that they get excited about. So definitely encourage you all to, that's where partnering with them would be really helpful. So that's PRAPARE more or less in a nutshell. And I'm going to hand things over right now to Nalani, who's going to give us a great overview of risk stratification.
Great. Thanks, Yuriko, and good afternoon, everyone. Now that you've learned how PRAPARE can be used to address social needs to better understand patient complexity, I want to spend some time discussing how one can incorporate social data into risk stratification models to improve health equity and demonstrate value. Next slide. So we always want to make sure that we're on the same page with language. And here on this slide, we have 2 terms, risk stratification and risk adjustment. Risk stratification is the process or tool for identifying and predicting which patients are at high risk or are likely to be at high risk, and prioritizing the management of their care in order to prevent worse outcomes. Risk adjustment is the method to offset the cost of providing health insurance for individuals who represent a relatively high risk to insurers. Next slide. So before I get into the presentation, I want to go ahead and kick us off with a polling question, which is, how comfortable are you with the concepts of risk stratification and risk adjustment? Great. So it looks like we have a few folks who are very comfortable with both. A good portion of folks who are comfortable with risk stratification, but not necessarily risk adjustment. Also a good understanding of the basic concepts. And then also a few folks who are not comfortable with either of these concepts. And all these answers responses are okay. Hopefully you walk away with a new knowledge on risk stratification, risk adjustment after today's session. Okay. Let's go on to the next slide. So it's known that a very small portion of the population, about 5%, account for half or 50% of medical costs. With risk stratification, we can divide patients into groups that have common needs so that specific complex care management interventions can be targeted to the people who most will likely to benefit. Next slide. To paint the picture, here we have a risk stratification pyramid that separates out different levels of risks from minimum to very high. With these levels, facilities can use risk stratification to help identify the right level of care and services for different patient risk groups so they can maximize efficiency, improve outcomes, deliver value, and prevent high costs. So in this pyramid, we can see that Joe is 90 years old and lives alone. He has 3 chronic conditions and is on 8 types of medications. He has fallen 3 times in the last year with 2 hospital admissions. Taking these factors into consideration, Joe is considered a very high-risk patient who may require more attention and monitoring than an individual such as Jen, who is within the at-risk category. Jen is 55 years old, who has been recently diagnosed with type 2 diabetes, has mild cognitive impairment, and is on 3 medications. Jen will still receive the care and monitoring she needs, but it will look different compared to Joe. By having risk stratification levels, we can match patients to appropriate interventions and use this knowledge to inform how we allocate needed resources to care teams, including prioritizing team workloads or identifying staff training. Next slide. So to recap, why stratification? Because when we use a risk stratification model, we can prioritize care for the sickest patients, reduce costs, and improve care. And we can also make informed care management decisions, such as prioritizing resources for those who need them the most, including identifying and implementing target comprehensive interventions for high-risk patients. Next slide. So current risk stratification models are significantly flawed, mainly because they rely on limited data to predict patient risk. These flaws include an inability to accurately assess patient risk, bias against racial minority patients, and bias towards patients with costly health conditions. For example, patients near the end of life or patients with costly chronic conditions such as end-stage renal disease. The most prominent risk stratification models also use claims and utilization data to predict patient risk. But research has shown that clinical claims and utilization data only account for 10% of the patient health outcome. Thus, the major issue with these current models is that they fail to take into account the numerous variables that contribute to patient health. Most glaringly, these models fail to incorporate social drivers of health, which have repeatedly shown to drastically impact both patient health and the cost of healthcare. Health centers have a unique model of care that positions them to address social drivers of health. And this is particularly important when considering risk stratification and sustainability, especially as health centers are held accountable for their outcomes, the shift in value-based payment, and the greater demands for evidence of impact and just the general growing competition. In using risk stratification, health centers can understand the needs of their high-risk, high-cost groups and create effective care management programs for these patients in an attempt to improve patient outcomes and reduce the cost of care. Health centers can also use risk stratification to inform the allocation of resources to care teams, prioritize care team workloads, and determine the types of staff trainings that are needed for care management. Next slide. So there are several important principles to take into consideration when implementing a risk stratification model. A risk stratification model that incorporates social drivers of health should be intended to inform but not replace clinical care judgment. It's encouraged to use a hybrid approach using quantitative data from a risk algorithm and qualitative data from the clinical staff judgment. Social risk stratification does not replace social risk screening. We also want to note that when using a national standardized numeric score, this can be important for policy and comparison with other providers. But localization of risk groups cutoffs is also important for informing care and target interventions at your health center or facility. Risk factors organized in categories aims to better understand aspects of each component for each patient to target the appropriate care, and using a point system will help to determine the levels of risk. Next slide. So here I want to wrap up providing just a quick overview of the benefits of using a risk stratification model. Using a risk stratification model can improve care management and interventions and demonstrate the complexity of patients. So this can include meeting the needs of patients in various risk tiers, including important decisions regarding interventions offered, prioritizing and addressing care management needs that can ensure high quality and timely care, and correctly assigning limited staff and/or resources for the highest risk patients. Risk stratification can also assist with standardization and national comparison. There, with a standard format, you can compare with others nationally, and that would allow for graded knowledge sharing and communication. It can also inform value-based care and cost savings, in addition to payment and policy, and help facilities qualify for PCMH and other quality incentives. Next slide. So that was a very high overview of risk stratification with risk adjustment and the PRAPARE S2H screening tool. And so I believe here we have a few minutes. We are open for questions before we move to our next presentation.
Thank you so much, Nalani and Yuriko. We do have a couple of questions I want to make sure we get to so that people can associate the answers immediately with your presentations. So in the Q&A, let me ask this question first from Katie Buckingham. How are risk factors weighted and tallied? Nalani, I'm not sure, or Yuriko, I'm not sure who wants to take a stab at that one.
Sure, I guess I can go ahead and try to take a stab at this one. So for PRAPARE in particular, we have a risk tally spreadsheet. So if an individual has a positive outcome for a SUH need, then they would receive a 1 and be identified as a positive. And then if they do not have an SUH need, they would get a 0. So at the end of all those questions, you would tally that up and that would give you a score.
And Nalani, is that, or Yuriko, is that customizable depending on how PRAPARE is integrated into the various systems? And sorry, Yuriko, please feel free to jump in before I augment the question in any way.
Sure. In terms of, just to expand on Nalani's question about weighted, there are health centers and even health networks that decide to designate a weight to each. That's a lot more sophisticated. That's dependent on like current data in your geographical footprint. I know at a health network that I worked at, they looked at the top 3 costliest health conditions. And so that's how they started figuring some of that out. There is a science to it, but it's quite, I know it's a little bit more advanced there, but you can weight it, but I think that's a little bit more sophisticated and requires a different skill set than just the tallying is important, but we also know that someone that has housing need is different from someone that has a transportation need. So that's just something to think about there. Were you going to ask, Bethany? I'm sorry.
I think that actually got to the question I was posing about whether that was standard or fixed, or if you've seen any variations. As you answer, I'm going to pose the next question, and as we pose the next question, I know we got a request to scroll back to slide 38. So another quick question that actually came in via the chat. I'm just going to remind folks, please help us out by posing the questions in the Q&A, but I don't want to miss this one. I think it's a little easier to answer. Is PRAPARE a proprietary, software or method? What are the competitors? Curious to know if this person in the audience is using one of the competitors.
Yeah. So PRAPARE is a registered trademark, and so there is a license agreement process that EMR companies do have to go through in order to build it into their platform. However, the end users, they sign a separate license agreement just since they're the end user. But that is that. Competitors, I mean, I don't know if I like the word competitors, but there are different screening tools out there. I know there's iHealth, there's a CMS, the ACH, I meant the ACH, the Accountable Communities Health screening questions. I think some of the EMRs also, they have their own screening questions that are built in. Trying to think what else. Nalani?
Yeah, I would say we do have several different types of license agreements. It is free to end users, but if you are working with an EHR or a digital software company, there is a particular agreement that they do need to sign with the national PRAPARE team before building it out. Also, I would say that with PRAPARE, many folks also combine PRAPARE questions with other SUH screening tools. So we do see that, and that is completely okay. As Yuriko mentioned in her presentation, the number one thing about PRAPARE is that it's a conversation starter. It's really to start that conversation to help identify the needs of the individual at the time of the appointment.
Mhm. Thank you. And then I'm going to, in the Q&A, hold off on posing the better care management question until after Keegan presents. But we are on slide 38, and I just want to make sure before we move away from the presentation that you provided, Nilani and Yuriko, that on slide 38, sorry, Reha, do you mind flashing back to slide 38? Reha's technology is working very quickly now. So on slide 38, are you able to explain in any more detail localization of risk group cutoffs and what that means?
Sure. So we know that there's an importance of having a national risk stratification model. So that way we can compare apples to apples, knowledge sharing, and communicate across different counties, different states. However, when we are referencing localization of risk group cutoffs, what we mean is that when you're looking at your community, you are the expert of your community. So if you determine that you want to do your risk stratification model and weight it in a different way compared to a county next door, that is okay for you to do because you are the expert of your community, and each community is going to look different.
Yeah. And I mean, I've even seen it in the same county. You have specific zip codes that have higher rates of something over another. So even in one county, you can get like asthma rates really high, and in another it's diabetes. So it's really interesting once you keep drilling down to more specific levels.
Agreed, especially important, and I'm glad that question was posed because it provides a nice segue for Keegan, who's going to dive into more of the mechanics around building your medical legal partnership. And I just want to remind folks that in the 9 conversations that you have as you develop your MLP, some of those questions are about how to tailor not just your screenings for social needs, if you decide that screening for all social needs is not the approach that you want to take, but then also for the interventions, even if you do screen for all social needs, how are you then going to tailor that legal services intervention for your MLP to make sure you're actually targeting, or the risk, you're targeting the risk and leveraging very limited resources in the best way possible. So I'm going to now, and thank you, Nilani and Yuriko. I'm going to now pivot to Keegan Warren, who will, let's go to Keegan's openings, or let me go to the quick poll and then we'll go to Keegan's slide. So I promise you all, this is the last poll to help with that segue between presentations. Tell us, number 1, does your medical legal partnership, for those of you who answered and said you do have one, use a standardized tool for screenings and referrals? It could be PRAPARE. It could be something that you've customized. Maybe it is one of the competitors, as one of our audience members noted, it might be out there. So does your MLP use a standardized tool for screenings and referrals? And then secondly, if yes, in other words, your MLP uses standardized screenings and referrals tools, are these tools also standardized in your MLP's service delivery workflow? So just want to make sure I emphasize that we are asking about standardization here of both the tools as well as how you utilize those tools in your service delivery workflows. All right, so we have about, going up a little bit more. Okay, we've closed out the poll and we have about 56% of you answering yes to let us know that your MLP utilizes standardized tools for screening and referral. And some folks are not sure. That's actually a pretty significant percentage, 22%, 7% of you saying no, you're not using a standardized tool. And for the second question, are you using those tools in a standardized way? About 41% of you said yes, 33% don't know, and 11% said no, you're not using it in a standardized way. So we are very happy to have Keegan Warren join us here today. to help you better understand how to build a standardized method for your screenings, your referrals, and your entire MLP service delivery workflow. Keegan, I'm passing the mic on to you, and I encourage everyone once again to utilize the Q&A to plug your questions in for the panelists and the host as we proceed. Thank you, Keegan.
Thank you, Bethany. I think we can get started by just taking a quick look at the iHelp chart, which most of you who are medical legal partnership practitioners are no doubt familiar with. iHelp is really our way in this field of distilling the way the connections between health and law, right? The ways that income and insurance, for instance, can impact health because income and wealth are great predictors of overall health. Housing and utilities similarly are structured in law as opportunities to as ways that we can use law, that the MLPs can take action to improve living conditions. The E is education and employment. These are things that have a bidirectional relationship with health, if you're familiar with them as social drivers of health or social determinants of health. And both are critical in order to have the resources to be able to access quality healthcare. The L stands for legal status. And I think the idea here is that the way that we define ourselves does not always map onto the way the government defines us. And when those don't match, we're actually at increased risk of poor overall health, but also things like disease and illness and even physical assault. And then the P for personal and familial stability. I always say just a reminder of the importance of having a stable home life and social networks in living our best lives. So that's just iHelp very, very quickly. Again, I suspect that MLP legal teams are quite familiar, but this can be a really useful mnemonic, particularly for our health center colleagues, to understand the ways that MLP can help take concrete and measurable actions to improve health. Next slide, please. Another theme that you'll hear from me, and I think you'll hear from other folks in this space, is that although we have this broad umbrella around health-related social needs, that there are a particular subset that are amenable to legal intervention, right? These are things that the lawyer, as a member of the care team, is particularly well positioned to address. And this is in that broader context, this broader idea that 80% of our overall health and wellness are all the things that happen outside the walls of our clinics and our hospitals, right? The places and the ways that where we're born, grow, work, live, worship, and age impact our health. Similar as the next slide, I think, which really demonstrates that in a family that's experiencing food insecurity, for instance, that you may have an interprofessional team that's kind of tiering that approach ideally, such that if you have, as this example here, a family that's struggling to be able to pay the rent, right, to stay housed, the solution may be that a community health worker is assisting with navigating the social sector and with obtaining immediate resources that address that acute crisis. That a case manager or a social worker is able to help this family leverage the system and make use of legal programs that are structured to improve health. But that and then the lawyer adds on to that, right? This is about creating complementary responses by addressing things in law that may be beyond the expertise of the community health worker, or really expertise of the traditional healthcare team, that things like the FMLA, et cetera, right? And then helping with appeals. It's one thing to help someone know what program to apply for and help them apply for it. Is a whole other thing to have an expert in understanding due process and how a hearing may overcome a wrongful denial, right? So complementary interprofessional teams. And then I think we have one other slide here that is really about recognizing that medical legal partnership is quite possibly the only intervention that really that really allows a healthcare team to address the individuals who are experiencing a acute crisis, but also tackles underlying policies, right? We are able, as lawyers, to add another tool to that toolkit that really helps achieve broader policy gains, because it's seldom, right, that individuals are experiencing a problem that isn't also a problem for an entire community. And for that reason, we have seen studies that suggest that mere access to counsel is actually really important for community health. So with that brief overview and reminder and an introduction, if we could go to the next slide, I want to spend the next bit of time focused on really adding to this very rich discussion two things. First, I want to talk about healthcare, and I want to talk about this kind of incredible moment in time where there is this increased emphasis on health equity, on social determinants of health, and situate that amongst this kind of larger shift to what's called value-based care. So I've got a few brief observations that I want to make that are really kind of directed at our MLP legal teams around this concept of value. And the idea is to recognize that by thoughtful and planful screening and workflows, that medical legal partnership is specifically able to kind of further that conversation. But we really just need to be deliberate about the ways that we seek to tackle that. Next slide, please. So again, I'm going to start with a quick overview of this concept of value, which is a really important term right now in healthcare, and relate that to medical legal partnership. So next slide, please. There are many theoretical models for thinking about value. One that every MLPer should know, and probably everyone on the medical side tends to know, but not so the legal side, is something called the triple aim. Now this came about in 2008. It is kind of this concept of three major goals of healthcare reform. And it was really targeted at healthcare organizations, by the way, and providers. It's about improving the experience of care, improving the health of populations, and reducing the per capita costs of care. Now that triple aim has grown. It's been reproduced as a quadruple aim in numerous formats. And then I actually saw last week where there were 5, and I don't know if they're going to call that the quintuple aim or not, but it keeps growing. The fourth one that I really like to talk about and make sure is evident in the work that I do with health centers is about the clinician experience, right? And I think that is so critical at a time where we have an increasing number of studies that address burnout amongst healthcare professionals. And we all know how very, very difficult as professionals it's been to do this work in the context of the pandemic. So workforce. We really want to lift up how a planful approach to screening and workflow and delivery of services should facilitate the work of the workforce, not add burden to it. Next slide, please. So another model for thinking about this, and in some ways I use this just to make all the lawyers go, wait, I thought I never had to deal with math again, is through this chart, and thinking about the relationship between points A and points B, because this is kind of where healthcare is trying to understand, right? There's this point where increasing the amount that we're spending on care can improve health outcomes, but at some point that kind of flattens out a little bit. And that's really represented here by A and B. And so if you look at the next slide, what this conversation about value is really trying to do is to jump off this curve, to say, how do we improve health outcomes without necessarily improving or increasing costs? Now, there's a lot of inherent assumptions in this particular model, in particular about what better health means. But this last bullet that I have up here is the one that I really think represents so much opportunity for medical legal partnership, and is why we want to be so deliberate in setting these up. And that is around health equity, right? This has become an imperative in healthcare, and that is only going to increase. My co-panelist so astutely noted that means that we have to understand, what are the health needs of patients, not only as individuals, but also across populations. And that is a great place for medical legal partnership to plug into. Next slide, please. There are other terms that I think MLP legal teams and really MLP champions teams should think about as well. Now, in the interest of time and recognizing that there is a future webinar plan that will go more into financing and more into this concept of value-based purchasing, I really just want to flag these for you. I don't, rather than talk about them right now, what I want to highlight is that these kinds of value-based terms are an opportunity for MLP to think about the values that are inherent in a particular entity's approach, not just value, right? This is the language of value-based care. How do you apply it to MLP activity? Next slide, please. Now, the last value concept that I want to introduce goes back to this notion of what health equity is. The World Health Organization defines equity as the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by some other dimension of inequality, things like sex, gender, ethnicity, disability, or sexual orientation, right? This is about nuance. This is not about equality. It is about acknowledging the differences in health outcomes that just don't have to be. And so again, a planful approach to screening through medical legal partnership, making sure we're documenting interventions, et cetera, is a really critical component of improving health equity. And that is a powerful concept right now for healthcare organizations as well as MCOs, as we're seeing an increase in accreditation and certification requirements. So next slide. This diagram is one that you have perhaps seen before, and I really have kind of three key themes for the remainder of my time. There are many approaches to screening, and I think we heard some of that in the questions that were asked. I think there are themes and commonalities that suggest best practices, whatever approach you're using. Second, workflows for meeting health harming legal needs also vary from entity to entity. What we want to see is that we're being planful in a way that increases efficiency and that creates a structure that really helps us multiply resources. And then finally, there are many, many stakeholders in a health center. There are professionals and medical staff, there are patients, there are communities. Everyone benefits from an organized approach to integrated care delivery. So next slide. Let's start with screening best practices. So on the next slide, again, I would note there are different approaches to screening, but most have several features in common in terms of their design. One, we want to make sure that we're authoring these by structural experts. I think this is an excellent opportunity for MLP legal teams as structural experts to make sure that the questions that are being asked are the kind of questions that facilitate an intervention, right? We want to avoid redundancy with other forms, and we want to be linguistically and culturally appropriate. And again, that's really important language around for helping health centers meet their health equity requirements. So what does all of that mean? One, we want to focus on structural barriers and on assets, not just deficits, right? So one way to balance this really very real need to sometimes be deficit driven is to start and end with asset-based questions. And I'll show you another tool momentarily that does exactly that. Two, we want to be cognizant of a patient's time and of their emotional energy, their literacy, their priorities. One of my co-panelists talked earlier about the difference between a social risk factor and a social need, right? And that is because even though we may be able to, in terms of research or literature, say, well, this is bad for your health, that doesn't mean that that's a priority for the patient. I always recommend that screening tools be at no more than a 6th grade comprehension level. If you're wondering how you achieve that, there are readability tools online. You can use Microsoft Word's built-in tool. It's the Flush Kincaid grade level tool. that's really easy to use to make sure that you are meeting literacy requirements. I also think it's really important to offer an option that allows a patient to say, yes, this is a risk factor for me, and that's really important for you in engaging in risk stratification and segmentation. But that doesn't mean that, again, that the patient wants assistance. And so, so you kind of need to understand that response is potentially bifurcated. Yes, I'm at risk for this reason, but no, I don't need your help with it, right? And then a couple of other things. One, you have to be really careful to make sure each question and the tool overall is trauma informed, not trauma inducing, right? That we're asking questions that provide insight and that have utility. So a tool or a question that asks about a piece of history that maybe helps a professional understand a really important health component of the patient may also be something that really misses a key element of the humanity of the patient, right? The threshold question I always encourage folks to ask is, what am I going to do with this response? And if the answer is nothing, again, to echo a theme from earlier, if the answer is nothing, then should you be asking that question? If the answer is provide a phone number, well, do you have a relationship with that community-based organization? Because if not, I think as a matter of respect for the community, for the patient, and for the community-based organization, that's a relationship that needs to be built before patients are referred. Our social sector, for better, well, not for better or for worse, really for worse, is often under-resourced in terms of technology and in terms of human resources. And then the screening tool itself and its design and implementation also really needs to make social needs care easier. It shouldn't make it burdensome, right? It should not make it harder for patients. And so, so one of the things that I will talk about here in just a moment is continuous quality improvement, thinking about how long does it take to complete your screening? And are there better ways to leverage wait time, for instance, to learn more about a patient's health harming legal needs, rather than at the time that maybe you conceived of as the best time to ask those questions. Regardless, the goal is that legal services become a routine part of care delivery, because legal care is healthcare, right? We also want to make sure that we are documenting, because again, that feeds that continuous quality improvement. Next slide. I promised that I would show you an example of a tool that starts and ends with asset-based questions, right? This is from the People's Community Clinic, which, if you know me, I've worked with and for many, many years. They actually decided to create their own screening tool. They call it the People's Tool. I can show it to you because it's absolutely open source. And it's tied into the various interventions that existed in the clinic and has evolved as those have changed. Or that are in the community and where there was a relationship present or one that could be built. This tool is not about screening solely for legal needs, because if you think back to those excellent slides from the National Center for Medical Legal Partnership, social needs are tiered. Not everything is amenable to legal intervention. Some of this is work for your community health worker, some of it's work for your social worker, some of it's work for your lawyer. And so this tool really sought to respect that. That we all have different skill sets, and the goal is to put those together to create a holistic response. You'll also notice these questions they're very specific, they're very action oriented, so that no matter who the right person is on the care team to respond, there is a response. That response is kind of baked into the way the questions were asked. If you're a litigator, think about the way you do direct examination, for instance, right? We know what question we're trying to, or what answer we're trying to achieve, and then we write our question. And this tool really comes from that mindset of leveraging the MLP legal team expertise around asking questions. These responses are linked with ICD-10 codes. They're also linked with legal services problem codes. Next slide, please. So how does People's decide who is the right responder? Well, that piece was actually built into the algorithm on the back end for the professionals to navigate, rather than trying to ask a patient to navigate them. And so this is the housing section. I'm sorry, if you could go back. This is the housing section, and it really just demonstrates that someone who screens positive might receive information about a resource. Other people might get a one-pager of legal information that the MLP legal team put together as kind of a clinical response. Others may be sent to a social services organization in the community, again, with a relationship already built for seamlessness and to be trauma informed. And then, of course, the legal team's on site in order to provide direct legal services. So here again, this is about creating equitable approaches that, just like in the rest of medicine and healthcare, are not one size fits all. And about creating a continuum of intervention. So that's just an example of a homegrown tool, so to speak. Next slide. I want to briefly note that thank you, that screening for health harming legal needs also happens organically, right? Physicians having a conversation, the patient says, oh, I haven't been eating enough. And maybe the physician says, well, here's why that matters from my biomedical expertise, right? But let me get you to that social worker or community health worker who can help you with this need today. Or maybe you're having a longer term problem where your SNAP benefits have been cut off and you need a lawyer, right? So even when even when screening, so to speak, is happening organically, we can still document that, right? Those are still needs that can be documented in terms of issue, in terms of referral, and in terms of intervention. Next slide, please. There are many other ways to, and I don't want to go through all of these in the interest of time, but there are many other ways that your MLP legal team can be plugged in to help spot health-related social needs or health-harming legal needs. So this first example, and actually, if you could go forward just one more for me. I'm so sorry, I thought I removed all the animation. Is thinking about complex care case conferences, right? Attorneys are skilled problem solvers, and in fact, sometimes I joke that the only thing that really separates lawyers from everyone else is issue spotting, right? It's that we understand systems, it's that we understand processes. And so you can have a pretty bare set of facts, and your MLP attorney may be able to help predict the likelihood of a health harming legal need that allows you to engage in that kind of quality improvement and improves patient care. The second one, if you could go to the next, please, is thinking about group medical visits. So the group medical visit is about kind of segmenting patients who have similar health needs, allowing them to meet together instead of in individual appointments with a clinician. So it's more than a 15 or 20-minute appointment. Instead of 8 15-minute appointments in a 2-hour block, for instance, you may have 8 people all together in a 2-hour block. This allows the clinician to consolidate his or her time to provide the basic medical information that would be provided to all of these folks individually. It is also can be really beneficial for patients because they're already clustered in that way with other people who are having similar health needs. And it is an opportunity for medical legal partnership legal teams as well, because again, you can address things or address health harming legal needs across an entire population. The third example is legal clinics. Most folks are familiar with this notion of substantive legal education, and then leveraging attorneys in the community so that many patients or community members can receive legal assistance at the same time. And then my fourth example here goes back to that conversation that Nalani was having around risk stratification. I think there you go. Thank you. And that's just segmentation, right? This is about using the data that you're creating to determine the likelihood of a health harming legal need based on the data points, as well as the likelihood of efficacy of a particular legal intervention, and then providing those services in a way that accords. So data science really can help MLPs multiply their frontline capacity. And hopefully, I think, the idea is to produce better data in turn that shows the importance of treating health harming legal needs as part of the delivery of healthcare. All right, next slide. And I want to leave plenty of time for questions at the end, but I also want to touch very briefly on workflow. So if you go one more slide forward, I would note here again that this notion of the referral order is really ground in the tradition of healthcare, right? That when a patient was sent to a specialist, there was a referral order put in, and then as a matter of professional courtesy, that the patient would be returned to primary care. And that's where we get that loop closing language. You may have heard, this is really common language in health centers right now, and that's the idea. We want to close that referral loop. So whether legal care is provided by curbside consultation, by some kind of institutional change, or whether it's through direct or referral professional services, all of which you can see here, it's really important to be thoughtful and to be respectful in considering the flow of information, and as well as how the patient moves through that whole person care. This means, or can help MLP legal teams be part of clinic level solutions so that individuals don't have to be in acute crisis, and they don't have to be screened before their health related social need is addressed. And of course, it also helps leverage that the MLP legal team has this really vital skill of professional advocacy, and is adding that to the health toolkit in order, again, to achieve those broader policy gains across communities that improve the health of individuals and, again, whole communities. The other thing I would note here is about this idea of a false positive. Sometimes, there's a positive screen, but there's no legal intervention that will solve the problem. And I really want to emphasize that doesn't mean that the patient isn't savvier for having that conversation with an attorney, for getting that counsel and advice. And that there are some kind of preliminary studies that suggest that can be correlated with better patient-reported health outcomes, just having access to that information. Okay, one more thing in the next slide is really kind of a guide for developing an efficient and meaningful legal referral order, and is about kind of 8 things that you want to consider. The first is convening an interdisciplinary team, right? You need representation from really all the clinical departments, because the way medical care is provided in PD and pediatrics may not match the way that it's provided in adult medicine. And that means you may need 2 different workflows, and that's fine. We want to build on those workflows that are present, not create new ones that feel burdensome to people. You can do this by soliciting membership in a work group. But regardless, I think obtaining protected time from leadership for everyone who's involved is really critical. Second, and this will be the next thing, you want to review current approaches for specialty referrals, to screening and tracking health-related social needs, right? Make sure legal teams understand what social screener your health partner is using. You want to think through your intake processes, and then through kind of basic questions around health equity, which really come down to, is a population being disproportionately affected, whether that's good or bad? And then 2, are you redressing the ways that populations historically have been disenfranchised from the medical system, right? So taking all of this together and making sure it's all being incorporated, again, to create a system that's lifting up the great work that's already happening, not adding to it. The third thing is to identify information that is needed to further these approaches, and then making sure technologically that's available. That may mean bringing in your EHR team on the health center center side. It may also mean bringing in the legal case management technology folks, because they may have a CSV file, for instance, right? And it's basically an Excel spreadsheet that can just be dropped into the EHR that makes it easier to document health harming legal needs. Next is making sure that your clinicians and patient-facing staff are trained. Written documents also help with institutional memory, so that when people move on, that information continues to exist. I recently created, for instance, a 20-second video that can be part of both orientation as we're going through this process, but also, part of orientation for new folks who are onboarding with HR. Next is training clinicians and other patient staff. We never want to assume that a new process is intuitive. And then we launch or relaunch. So the next one, please, is launching or relaunching. After that, is soliciting and obtaining feedback. And the final step is making sure that you are creating and running reports that allow you to measure legal care provided, to stratify your patient panels, to improve health equity. And that I think an effective workflow and referral order will make it easier to demonstrate the value of integrated care and to further institutional priorities, goals, and requirements. Rinse and repeat here. Continuous quality improvement is the goal. I'm going to pause here. You have some additional slides with great resources from the National Center for Medical Legal Partnership that will be in the slides that are provided around follow-up, around closing the loop, and around continuous quality improvement.
Thank you so much, Keegan. We know you really packed a lot of content into your slides, and I wanted to make sure everyone knows that this entire slide deck with both presentations by NAC and by Keegan Warren Clem will be shared along with the recording on the Medical Legal Partnership website. My Zoom actually shut down for a moment while Keegan was presenting, so hopefully it didn't cause tech issues for everyone here. But there was a great question in the Q&A that I want to pose to Keegan before folks log off. It's from Marlene Putnam, who is really noting one of the challenges about developing medical legal partnerships. So Keegan, I'm going to pose this to you. What Marlene is essentially noting is that, legal cost can be, or legal services can be expensive. This is something that is very well known in the legal services community about one of the barriers to, or access to justice, quite frankly. And so for certain states, they haven't seen, APMs or value-based methodologies incorporate the cost of medical legal partnership. Do you have any tips for really balancing the investment into services like civil legal services through medical legal partnerships that help to address the social determinants of health with the cost related thereto?
Yeah, absolutely. I mean, I think ideally APMs are built in a way that expressly includes legal services. And that is a part of a much larger conversation that needs to happen. One easy thing that everyone can do to further that conversation is to make sure you complete the environmental scan. That environmental scan is designed to help those of us that are doing policy work, amongst other things. But one of the goals, I think, is that it will help enable and further the conversation around APMs, alternative payment methodologies. This is about that shift from volume to value in a way that facilitates including legal services. The other thing is, are there folks that are doing this anyway? Yes, right? Because HRSA defines legal services as enabling services, there is kind of some built-in funding that can be available. It comes down to prioritization. It comes down to using planful screening and workflow and loop closing to demonstrate value to your health center. But there are other folks who are working either through their health center and to have conversations with MCOs, right, that are getting the funding more directly to do either like per member per month arrangements, or to do a monthly kind of capitated payment for this population, et cetera. Those exist, and I think will be the subject of a future a webinar, and are definitely really rich conversations. So thank you for that question.
Mm-hmm. Agreed. And folks, let us know if you need help finding any of the resources on MLP funding and financing on our Medical Legal Partnership website. Lastly, I just want to note that there's a great final question in the chat that provides perhaps some takeaways for the entire audience. And so Yuriko and Alani, I'll just ask and thank everyone for hanging out just a minute longer here on today's webinar to help us take it home with this last question. Are there core components of a health center, especially those with medical legal partnerships, that make it more amenable to better care management? Yuriko, do you want to take a stab at that, and then I can pivot to Keegan?
Sure. I'd say probably the first thing that comes top of mind is that health centers are typically located, co-located with other service providers, or they are within distance. So I think that's something that's really important, that just makes them better for care management. I think when you think of a traditional hospital or network, they're usually somewhere that may not be as accessible or really not well integrated in the community. So I think that's something that makes it pretty it facilitates care management to a greater capacity.
Agreed. Thank you, Yuriko. Keegan, I don't know if you want to add anything to that.
I mean, I think one of the core components that's really important is that health centers under HRSA are doing or supposed to do case management services. And there's really a lot of map on between case management services, between services that enable access to care and the work of public interest lawyers. So really think about how do you leverage that, and some of that, y'all, is just about changing your language. It is just about legal teams. You have to learn the language of healthcare.
Agreed. For the Health Center folks, the MLPs that have tuned in today, we can't thank you enough for joining us to learn more about how to improve those care management, case management, enabling services, and healthcare strategies by conducting the social needs screening, doing the risk analysis and stratification, going through what we know are steps that are cumbersome and sometimes painful along the way to do evaluation and quality improvement work. But kudos to you all for really leading the way and helping to improve health equity for, at least for the Health Center bunch, over 30 million people around the country. So thank you for joining us again. We will be continuing with this webinar series. Part 3 is coming up on November 1st, where we'll talk about some promising practices in training MLP teams to better meet the needs of providers and patients. So how do you create that workforce development, those trainings for MLPs? And then on November 9th, we'll be joined by our friends at the Veterans Administration to talk about really creating a no wrong door for veterans in our communities that are served across multiple institutions and also cared for by MLP teams. I want to thank Keegan Warren, Yuriko de la Cruz, and Ilani Tarrant, as well as the National Center for Medical Legal Partnership team and our entire audience for joining us today. Please take a moment to fill out our evaluation survey. It is very important for us to be able to report to HRSA if you enjoyed this webinar and how we can continue to improve future resources and presentations to assist you in your needs. Email us at ncmlp@gwu.edu if you have any further questions. And again, thank you all for joining us. Thank you, Keegan, Yuriko, and Ilani.